Hello, my name is Adrian Brown. I'm an alcohol nurse specialist working in a general hospital in London in the United Kingdom. I work as an alcohol nurse specialist as part of a brief advice, brief intervention programme, and also providing hospital liaison to people who are dependent on alcohol who've been admitted to the wards. The service we provide is seen as a specialist clinic, and I will talk about establishing those kind of clinics within a hospital or within a community setting, some of the things that we've done to make people know that we're about and how to refer to us. I will say something about how you can make interventions related to alcohol work within your field. In establishing our clinic, we had to set about finding what our colleagues expected of our specialism. Alcohol is a field that many people know about, many people have an opinion on, but not many people know how to progress. So, like any speciality, it required a lot of information to be given to our colleagues about what we would be prepared to do and what we could offer to their patients. The first step then was that publicity and consultation in talking to our colleagues on the wards about cases that they'd seen, about what had happened in the past when somebody had been referred. This can seem time-consuming at first, but simultaneously provides you with the information that you need to run an effective clinic, and also publicises that clinic, encouraging people to make referrals. Expectations that people might have from the service you provide are certainly not always what your expectations of those clinics can be. On those ward visits, it was useful to link to the ward rounds where patients were being discussed, introducing yourself and spending time with the medical and nursing staff to find out about the cases that they were already dealing with. It may be useful that they know that there is a case that they already have in mind to refer to you, but you may be able to tell them of other cases that you might be able to offer advice or support to that patient. If there are clinical guidelines within the hospital or the department that you're working, it may also be useful to relate your advice to those guidelines. Later on in the process, you may even find that those guidelines need to be reviewed, need to be updated, and this is again a useful way to make yourself known to key colleagues who might in future make referrals, but more importantly, might in future carry out some of the work that you would provide for themselves with their own patients. One important factor in establishing a clinic is to have a referral process which is easy for your colleagues to understand. There may be some minimum information that you require. So a referral form can often become an unwieldy, lengthy document. By all means, gather that information about the referrals that you are seeking, but also make it well known that people can contact you to ask about cases, because often that information can be gathered much more effectively in a conversation, face-to-face or over the phone. The simpler the referral process is, the more useful your colleagues find it, the more likely they are to refer to you, and therefore the more likely that the patient will benefit from the specialist role that you provide. It's important that people know that you're there. Spreading the word, as I've said, can be done from visiting the wards, but accessing bulletins, accessing news within the department, within the community, providing mail shots or posters around the department is another useful way of establishing links with potential referrers. But once again, there is only so much that you can carry in a brief note. So the face-to-face conversation, attending team meetings, answering questions, and also gathering expectations from people, because in some cases you may be able to develop the service, modify the service on the basis of their feedback. Once you've spread the word in this way, hopefully the referrals will start to come in. It's important that you clarify your expectations of your colleagues, that you make it known what you can and cannot do within your intervention or assessment. It may be an assessment that leads into advice and information about care planning, for example. It may be an intervention that helps with discharge planning. These items and this feedback from these interventions and the feedback that your colleagues give you can be used to inform training and education that you will later give to them. Of course, you're often working as an individual within a larger environment, the community or a hospital, and you're only one person to provide that specialist intervention. Working alone, you cannot see all of the patients who may be needing that intervention, so the training and education is required to give your colleagues skills to provide them with the knowledge to carry out some or part of those interventions, and will also have the benefit of improving referrals that they make in future. Your colleagues may want to know some specific information, such as in my own field, the knowledge of how to ask about alcohol can be surprisingly difficult for people to do. This can be something as simple as asking, do you drink? Which provides people with a stumbling block of yes or no, does not tell you how much somebody drinks and therefore how much of a problem that might be. So it's important to be clear and to find the level of knowledge of your colleagues before teaching them to carry out something perhaps more complicated, such as a screening. The benefit of a screening tool can be to simplify that process and again clarify your referrals, but it may be that some screening tools provide people with difficulties. Is it a judgmental area? Is it an emotive area which they're not used to dealing with in their general practice? By documenting this information and by giving them feedback on that information, we do hope to develop their skills in this area. That's an area for my specialist field, and there may be something different for yourself, but once again this goes back to that introduction phase, finding out what your colleagues know and finding out what they would expect you to do. In your own practice, you may come into contact with people with alcohol problems, either alcohol dependence or alcohol misuse at a higher level, causing harm to that patient's health. Sometimes the problems that they experience may not be health related at all, but social, related to their family or to their employment or to their accommodation. I will say a bit about the different levels of alcohol dependence and alcohol misuse, and how you can recognise and how best to approach people with these issues. There are obvious cases. The person who comes to appointments intoxicated may not be able to understand or keep to the conversation that you're trying to have. It may then be appropriate to point this out to them and ask them if they would like to approach this in a separate session. Deal with the reason for them seeing you as a specialist before moving on to the alcohol issue. It may be, however, that the alcohol issue, the intoxication, is just getting in the way of your interaction, and you may have to postpone that also. Once a patient has sobered up, you may find that they are in fact dependent upon alcohol. It's important here not to advise people to stop drinking alcohol without clearly stating that they should reduce safely or seek some specialist help. There may be specialist help available in your local area, and you should find out where that is and how best to go about referring people. But there may be some information that you can give to the patient yourself about safely reducing. Seek advice and seek information on how to do that, but the key thing here is never to tell somebody to stop drinking abruptly because of the risks of severe withdrawals. If a person attends and they've actually tried to stop drinking and they're already showing signs of those withdrawals, have an idea about assessing whether the severity is enough for them to need to go for a medical emergency and attend the local A&E department or local emergency service. A person who is shaking and sweating is showing the early signs and symptoms of withdrawal may benefit from actually having to have some medication which takes away those withdrawals, such as benzodiazepines or chlordiazepoxide is a commonly used medication here. It may be, however, that these drugs are not available and the person needs actually to have a small amount of alcohol to take away those withdrawals. Remember that we say this because it is a risky medical emergency, and untreated alcohol withdrawals can cause death if the person does not go to emergency services. Once you've dealt with the more immediate alcohol-related issues, you may find that the person with dependence wants to get some help. There are known treatment services around the world, such as Alcoholics Anonymous, which can provide a lot of support for those people who want to stop and want to stay abstinent. It may be that a person needs more medical prescribing support before they get to that stage. And again, you should know where your local services are, if they are available, or how somebody would go about getting that treatment. If that treatment isn't available, you may want to look into specific treatment plans and guidelines for those reductions and information leaflets that you can provide to the patient themselves. Would not expect that you would become an expert in alcohol detox, but having the information available is the key here, if you don't have a service to refer to. These have been obvious cases where alcohol is an issue. Sometimes the case is less obvious. As I said, the person who is experiencing difficulty with their family may only put that problem down to family issues, but it may be directly related to their drinking. Once you would ask this person about alcohol, they might be dismissive and say that they don't have a problem, that they don't drink too much, that they drink only as much as all of their friends around them drink. This could be somebody denying the problem, and it's important to ask about alcohol in a very straightforward way. If you make this seem like it is part of your normal practice, people who might otherwise become hesitant, they might otherwise hide the truth, would be more prepared to give you information about their drinking. So having a simple screening tool that asks, do you drink alcohol? How often do you drink alcohol? How much alcohol do you drink on the days when you do drink? Simple questions like that can set somebody on the road to talking about alcohol in a non-judgmental manner. When we're providing brief interventions within the alcohol field, we use a model called FRAMES. This is referenced in many of the manuals on this work, and I will provide a reference at the end of the talk. FRAMES stands for feedback, responsibility, advice, menu of treatment, empathy, and self-efficacy. The feedback here is that which you give to the patient having worked out their alcohol consumption as previously described. You may know that this level of consumption is hazardous, that is linked with certain health conditions. It may specifically be related to the health condition that they are seeing you for. It may also be related to other conditions that they've identified within your assessment. It may be an issue within their social life. That is to say, if they are aware that their family are always criticising their drinking and they had not yet felt that this was because of the drinking, you may be able to emphasise that in a non-judgmental manner. The E in FRAMES is for empathy, and that's very important here because talking to patients about things that they already feel that they've been judged about, you have to know how to measure that. So empathy and taking the patient's side is often the way it is seen, but it's more about encouraging them by not being judgmental, by not taking up a punitive role that they may have experienced in the past. The advice that you give them may be something as clear-cut as that they would be advised to stop drinking. We know that abstinence improves the health in many conditions. We know that it's vital in certain alcohol-specific conditions. Liver damage as a result of alcohol means that the body cannot cope with that level of alcohol anymore. Certain mental health problems are exacerbated by alcohol consumption. This is when you need to give clear advice on what the patient should do about drinking. Sometimes the advice might be on how to cut down. It's important to say to people that they should not reduce abruptly, that they should not stop drinking, abruptly because of the risks involved. But it may be that there are ways of cutting down by drinking things which are less strong in alcohol, or drinking less often, or by having something to eat before they go to a drinking session. Obviously, this information is for the person who cannot or does not want to stop drinking completely, and it's important to be clear about the patient's choice of goal. Menu of treatment services may be available to you through your local substance misuse service, your local alcohol services, or there may be other specialists which provide that. If there isn't such a service available, then you may want to find information leaflets to give to the patient about what they themselves can do. And self-help information is often available in literature, in published leaflets or books or available on the internet. The final thread of frames is self-efficacy. You are advising the patient, you are giving the patient the information, but it's their decision to change or to become abstinent or to change the level of their drinking, which is important here. People who are coerced into stopping drinking may successfully do so, but once they reach the point of relapse or the point of slipping back into their drinking pattern, it's easier for them to say that it's someone else's objective, not their own, either consciously or subconsciously. So always give the patient the lead on what they choose to do and encourage them to make choices that are most beneficial to them. So that's frames. Remember, feedback, responsibility, advice, menu, empathy, and self-efficacy. Of course, this is not just something for alcohol interventions, it's something that we learn and we use through all of our interventions in health and social issues. So I've told you a little bit about establishing a clinic within a new environment, with new colleagues, and how to prepare them and their expectations, how to give them feedback, and how to promote and develop the service. I've told you a bit about alcohol interventions that you can use within your treatment, and remember that you're not necessarily carrying out a specialist alcohol intervention, but you may be getting that person to make the first connection, consider the first steps that they need to take. Remember that they may not have come to you for an alcohol-related issue, and they may be surprised when you bring that up. So I hope this has been useful, and if you do find out where your local services are or what local services are available to you, that you will call upon them when the first steps require somebody to take that one step further. Thank you.